Thanks for joining us on this. This is the third, actually, in our GI series of webinars. Some of you might have joined us, last year now it is, with Artie Kathrani, and Artie presented 2 webinars for us, one on chronic enteropathy and one on fat-sensitive diseases. And I'm so delighted today to follow that one on fat-sensitive diseases with a really practical expert-led webinar from Susan Campbell, who I'm sure many of you know. And I'm really delighted to do this because Susan kind of takes sort of what we might sort of from the initial diagnosis and takes those owners and those patients right through to kind of administering nutritional care, doing follow-ups, doing nurse clinics and so forth. So that patient really, really benefits from the nutrition that it's been recommended. So really delighted to have Susan with us this evening. Before we kick off, I'm just going to read out Susan's bio here, and then I will see you after the talk. I've got a short presentation on one of our products, and then we'll have the Q&A thereafter. So Susan, thank you so much for joining us this evening. Susan began work at the Royal Dick School of Veterinary Studies, that's Edinburgh Vet School, in 2000 and qualified as a veterinary nurse in 2003. Her interest in nutrition and internal medicine led her to undertake further study while working full-time throughout all specialist areas of the busy referral hospital, and she completed her diploma in advanced veterinary nursing in 2009. Her love for intensive care nursing led her to take up a senior role at a private referral and emergency hospital in Glasgow for 2 years, where she completed further study and gained a certificate in emergency and critical care. She then returned, joining the senior veterinary nurse team at the Royal Dick School of Veterinary Studies, and took up the role of nutrition nurse in 2015. Susan gained a certificate in small animal nutrition in 2018, and her passion for nutrition has grown the service, where she continues to lead the Fit for Life Nutrition Care Clinic. And I've had the privilege actually of going up and seeing Susan in Edinburgh running her clinics, and I can tell you, and it's been wonderful to see her expertise put to such great use in helping her patients. So we have no one better, really, I think, to talk to us about the nutritional care of our patients and client care than Susan. So I'll hand over to her now.
Thank you very much, Livy, for that lovely introduction, and thank you very much, everyone, for joining us this evening. I'd like to just share a few thoughts with how nurses can master nutrition and the nursing care of the fat-sensitive patients. So tonight's lecture will be focusing on dogs. Our learning objectives are going to be to develop an awareness of the importance of dietary fat-sensitive disorders in dogs, to understand various fat-sensitive disorders and develop appropriate nutritional management plans for these patients, to gain an understanding of dietary transitioning and how to monitor progress through nurse-led clinics, to recognise that it may be possible to transition these patients back to regular diets and how we can record the progress of our patients within clinical notes and make these decisions along with our vets. And then to understand how to gain the client trust for better incorporation of the dietary recommendations that you've made so that the client can implement these in that pet's home. So first of all, thinking to fat itself, why do we need fat in our diet? And I guess when we think about, our own nutrition and how we enjoy our food, we think of fats and lipids providing energy. And also, as you can tell from my voice, I am from north of the border, so I'm Scottish, and we have a tradition of dipping many foodstuffs into batter and putting it in the deep fat fryer to ultimately make it taste better. And fat does have that quality within pet foods as well. So an amount of fat within pet foods does increase the palatability for our dogs. But as nurses, when we think back to how we learned our anatomy and physiology, when we learned the digestive system and we learned about nutrition and how nutrients were digested, I think fat is the most complicated one that we had to learn. And that's because it is the most difficult nutrient that the body does have to digest. digest. So there's multiple organs involved in the digestion, the absorption and the metabolism of fats. So lots of things have to be working in sync for this process to happen smoothly. So if we think to the stomach releasing lipase, breaking down the fats, bile from the liver emulsifying those fats into smaller droplets, pancreatic lipase, enzymes in the small intestine, converting them into the fatty acids, which are then ultimately absorbed through the intestinal wall, through those lacteals and into the lymph vessels. So the fats are actually absorbed through into the lymphatic system and eventually ends up in the blood system. But it's got this extra step of going through the lymphatic system first. So the body kind of responds to the presence of fat in food, and it actually slows down the GI motility in the presence of fat. And that's to allow all these processes to happen fully so that fat is digested properly. When fat isn't digested properly in the small intestine, if undigested fat goes into the large intestine, that's the sort of main cause of diarrhea that we see in our patients. So having this understanding of all the different organs together just gives us that basis of what fat does in the body and how it's required. So fats, there are some essential fatty acids as well. So it's not just all one type of nutrient. There's lots of different types of fats that we eat every day and our dogs eat every day in their food. So saturated fat, unsaturated fat, polyunsaturated fats, lots of different types of fats that the body digests. But the essential fatty acids, so linoleic acid, alpha linoleic acid, EPA, DHA, these are all considered to be essential. So the body needs an amount of these every single day within the food that the patient eats. These are all long chain triglycerides, and the linoleic acid, omega-3 fatty acid, alpha linoleic acid, omega-6 fatty acid. So again, essential for lots of different processes in the body, for skin health, for cell and organ function, for immune system function, for healthy growth, lots of different roles within the body. So fat is required every single day. That energy density from fat, so every gram of fat does provide more than twice the amount of calories that both protein and carbohydrate provides. So 8.5 calories from every gram of fat that's in the food. And also, we need fat present in the food for the absorption and storage of certain vitamins. So vitamins A, E, D, and K that we class as fat-soluble vitamins, they require fat to be present for them. So then when we think about when all these systems go wrong, so when we have our patients in with us and they've been diagnosed with a fat-sensitive disease, these are the sort of three main things that respond really well to a change in dietary management. But I've got to be honest, lots of our inpatients, because they are within our hospital, they are under stress from being in a strange environment, they've perhaps been starved for a period of time, or they've been vomiting, so therefore they've not been intaking their normal calorie intake for a period of time, or they've been under general anaesthetic or any sort of diagnostic procedure where they've been fasted. They're all in that recovery phase. So to be honest, most of our inpatients, the vast majority of our inpatients, will benefit from a slight reduction in fat within their food when they're in with us as inpatients. And that will help with their digestive processes so that they, can eat their food and it transitions out of their stomach and through their small intestine into their large intestine in a more timely manner, rather than, leading to sort of gut stasis and ileus and things like that we often see with our inpatients that then require more medications to get their intestines moving again. So the three sort of main fat sensitive disorders that we tend to see: hyperlipidemia, pancreatitis and lymphangiectasia. Alongside the third one, the protein losing enteropathy part is one of the parts where we as nurses are really get involved with the nursing care of those patients to get them back on their feet and healthy again. So hyperlipidemia is a higher than usual level of lipids within the bloodstream, and usually when we are running blood parameter panels, we see these as raised triglycerides or raised cholesterol, or sometimes both. When we are processing our blood tubes, we'll often see that milky or turbid appearance of the plasma or serum within our blood tubes. So sometimes we can see the lipemia with the naked eye without actually having to put the blood through any sort of blood analyzer. And this kind of turbid, milky appearance usually is an indication that there's an increase of triglycerides within the blood. So what this means is when we see these patients back for further monitoring, as nurses, we want to make sure that our clients are aware that these patients must be fasted for 12 hours before we take their blood sample, so that we can get a better idea of what their triglycerides are in their blood then. So that's the kind of really important part of, if they have hyperlipidemia, they need to be fasted for 12 hours before we do their blood sample to check their levels again. So hyperlipidemia can be a primary disease. There is a genetic kind of component to it. We definitely see it more in miniature schnauzers than any other breed of dog. It can be a secondary disease as well, though. So we do often see this in patients that have endocrine diseases, so things like hypothyroidism, diabetes mellitus, or hypoadrenocorticism. We can sometimes see hyperlipidemia as a secondary to those endocrine diseases. And the presence of hyperlipidemia can make these patients more prone to developing pancreatitis and more prone to hepatobiliary disease and also ocular disease as well. So it just means we have to watch for a few more clinical signs in our patients as we're monitoring them. So on to pancreatitis. This is inflammation of the pancreas. So the pancreas responds to the presence of fat in the digestive system, and it produces lipase. And again, pancreatitis can be an acute disease where it happens very quickly. So this is often what we like to call raiding the bin. So some sort of very high fat meal has been usually stolen, and then the body can develop pancreatitis, but it can be a chronic thing as well. So again, there's kind of two parts of the disease. Sometimes it's just a one-off pancreatitis episode, but sometimes you can get flare-ups of pancreatitis and it becomes more of a chronic long-term disease, which again just has to be managed more carefully. What I would say is pancreatitis, either acute or chronic. If it's chronic and they're having a flare-up, or if it's acute, it is often one of the most painful things I see our patients going through. When they have a sore pancreas, they can be extremely painful, and so they often come in as an emergency. Lymphangiectasia. So this is where the small intestinal, the gastrointestinal tract lining, so those specific enterocytes that are involved with the absorption of the fat, so those villi, and then within the villi, the lacteals, these are what become inflamed. So again, these are the tiny, almost molecular level parts of the body that are having to absorb the fat. And when they're inflamed, they can become so inflamed that they actually rupture. So that's when we get that protein losing enteropathy. So the lacteals rupture, they get a loss of lymph back into the intestinal lumen. When this continues without any treatment, that patient will then go into a negative protein balance, and we'll see differences and changes on that patient's bloods. So we'll see a reduction of the blood proteins, and the main one we tend to look for is albumin. So you'll see that low albumin on their blood parameters. And this is the sort of protein losing enteropathy part. So again, it can be a primary disease. And to be honest, the cause is often very much unknown. There's lots of studies going on to try and recognise patterns of patients, or, is it in response to certain medications or things like that? But it's often quite unknown why patients develop this disease. But it definitely can be secondary to other gastrointestinal diseases. So our chronic inflammatory enteropathy patients are more at risk of developing protein-losing enteropathy if they're having a really bad flare-up. We often sometimes see this as a secondary part of intestinal lymphoma as well. So our oncology patients, we tend to keep an eye on their protein levels very closely so that they don't develop this protein-losing enteropathy part as well. With regards to the sort of disease processes and the very specific symptoms with each of these three diseases, and the diagnostic workup tests and diagnostic imaging involved with these, and the medical management, there was actually, Libby mentioned it earlier, but Archie Kathrani done a fantastic CPD lecture all about the fat-sensitive diseases, and she goes into a lot more detail on these three with regards to diagnostic imaging and medical management. So if there are nurses in the audience who are doing advanced nursing qualifications, or are working in referral practice every day and you're seeing lots of these patients, especially very complicated patients, or you're working in an emergency clinic and you're seeing these pancreatitis patients through the night, or the protein-losing enteropathy ones where they're, very closely monitored and, in our intensive care units and things, then I would definitely recommend catching up with that lecture. You will find it on the e-learning platform as well. It was recorded on the 7th of October last year, but it should still be available for you to watch as well. So, where nurses come in really importantly with looking after these patients is gaining that nutritional history. In this picture, I've picked a scientist because, some people think it's a bit of a science to gain a nutritional history from a client. It is quite a lot of investigations, questioning, specific questioning, but also open questioning of our clients to gain that full nutritional history. So often it's a case of asking clients, walk me through a day of what your dog eats from first thing in the morning till last thing at night, and let the client, work through their way of not only what that dog is fed at home, but how they're fed. And then you'll get an idea of who else in the family is feeding the dog. Do they go to daycare? Do they go to groomers? Do people pop in and feed the dog at lunchtime? That kind of thing. So you're getting that full nutritional picture of that dog's food journey throughout that day. There's also quite useful tools available. So you can get some simple or extended nutritional questionnaires. They can be really useful for us to use within our consult room, for just to remind us of everything that we're asking our clients, or we can electronically send them to our clients or give them a paper copy for them to fill out at home. Especially if it's an extended one and maybe the client can't remember the names of all the foods and all the treats and all the supplements. If they have that at home, they can take it home and open their cupboards and write down all the names of all that dog's favourite foods that they eat every day at home. Then they can just send it back into you as well. So if the patient that we're looking after has an acute disease, we want to be asking our clients if there's any recent changes in the main diet, any addition of new treats that they've maybe not had before, any new supplements that have been recently added, any foods that they've recently started giving to help give medications. We want to check if that dog has had any access to food from other pets. So, for example, if we think about some of the higher fat foods that they might have access to, so I'm thinking kidney foods are often quite high in fat content. You know, has that dog been into the cat's kidney food and scoffed half a bowl full? That's the sort of thing you want to check for. Has that dog stolen any food, any human food from at home? Have they had access to the table? Have they had access to the bin in the kitchen? Have they been outside and got access to food outside? So in the winter, when we're all feeding the birds out in the garden, has the dog eaten from the bird table? Some of these fat balls and things, they are that. They are literally fat with a few seeds in them. Has the dog got into any bins? And the sort of rise of us recycling our food waste. We all put out our little caddies with our food waste in. They're often not that secure for both wildlife and for dogs. So have they got into a food waste bin? Have they got hold of anything toxic? That's always worth asking as well. Any foodstuffs that are toxic, any plants, both within the house or in the garden, any medications that dog has not been prescribed, especially human medications that are a lot stronger than our dog and cat medications. Has there been any access to that? Compost. I mean, I have a spaniel. They love a good sniff around the compost bin. So have they actually eaten things that are, rotting down in the compost bin? And any access to chemicals. So any, garden chemicals that have been stored in the shed, in the garage, has the dog had access to that? Chronic disease. Often if there's a chronic disease going on, there should already be a nutrition plan, a management plan in place for that dog. So we want to then check, in addition to that management plan, has anything else changed? So it can be main diet. Have they changed even between the recipe or the flavour of that food? Have they switched the proportion of wet and dry food? Are they maybe feeding a few more dry kibble and a bit less wet food? Those kind of changes in the balance of their daily nutrition plan. Has the client made any recent swaps from within the life stage foods? Have they gone from an adult food to a senior food perhaps? Have they changed any of the daily volumes? Are they needing to feed more to perhaps get daily medications in? Or have they stopped weighing it out and they've started measuring it out and actually they're getting more access to food? Are they using any tasty toppers? Has this dog gone off the food that it's been managed on for a period of time and the client's having to add a wee tasty topper to get them to eat it? Are they adding any new supplements, any new dental chews, puzzle toy fillings, flavoured medications as well? Some of the sort of newer medications, the pharmaceutical companies are making them flavoured to increase palatability so that clients maybe don't have to wrap them in other foods. But these new flavourings, some of them can have, some are synthetic flavourings, but some can have a bit of protein and other flavours and things in there that might just be upsetting the balance for the dog that, we're looking after. Flavoured toothpastes as well. Again, some can be a synthetic flavouring, some can be an actual protein within that toothpaste. Has any of those changed recently? And then again, if it's a chronic disease, the client should be already, keeping a good diary of what's working for their dog just now. So they'll often give you a good idea of the length of time that each of these changes have taken place and the dog's response to any of these changes. So they'll often give you a nice, good diary update. So when we're thinking about putting our dogs on a low-fat diet, how much fat is in the foods that we have readily available to us? So fat can be recorded in 3 different ways by pet food manufacturers. There's the as-fed fat, the dry matter level of fat, and then there is the grams of fat per 100 calories of metabolizable energy that we're going to shorten to ME for the rest of this talk. So wet foods are between 70 and 80% moisture as water, and they're about 1 calorie per gram. whereas dry foods are about 10% moisture as water and about 3 to 4 calories per gram. So you can see that even between wet foods and dry foods, if we're just going by the as fed amount of fat, they can be hugely variable between the different foods. So the as fed is the grams or percentage of fat per 100 grams of that food as it is fed. And it doesn't account for the differences in calorie density or moisture content of these foods. So it means it's quite hard for us to compare between different products and between wet and dry foods within the product range. Dry matter can be a little bit more useful to us to help us compare. So these are the grams or percentage fat per 100 grams of dry matter. So this calculation removes moisture content as a variable and allows us to compare the fat content between a wet and dry food. So this can be more useful for us, but again, it doesn't account for the differences in calorie density between foods. Different manufacturers will have different calorie densities of their low-fat products. So again, the dry matter is a little bit better, but still isn't the best. So the last option is the grams of fat per 100 calories consumed. So this removes the two variables. It removes moisture and calorie density as variables. So this allows us as nurses to do a full comparison of the fat content between different foods, between different manufacturers, different foods within a manufacturer's range, and between wet and dry foods. So this is the best one to use. So when we think about our patients, so the sort of three main diseases, we have a few different choices. We have our intact protein foods and our hydrolyzed protein foods that can be low in fat. So depending on the disease that's actually been diagnosed, both of these can be useful to help manage our fat-sensitive patients. So for most inpatients, as I said, reducing the fat can be really useful. So under 4 grams of fat per 100 calories ME is a really useful thing for all our inpatients to make that food very easily digestible. But when we're thinking about our very fat sensitive patients, and the most fat sensitive ones will be our protein losing enteropathy dogs, we are actually trying to aim towards 2 grams of fat per 100 calories ME. So aiming towards that 2, if it's just above the 2, again, we trial them on these foods and see how they get on. We also want to make sure that these foods are complete, balanced, highly digestible proteins. So the proteins within here must be very high biological value, because these patients are unwell, they are mending and repairing their bodies, so we need to have a good amount of good quality protein within their foods as well. So it's not always just about the fat, we want to make sure they've got a good protein source within their foods as well. And again, if we have different ages of dogs, we want to make sure that that the product is aimed for dogs and is life stage appropriate. So if we have a puppy with a fat sensitive disorder, then we want to pick an appropriate food for growth. So we still support that healthy growth. Some dogs do need a wet and a dry product option if they're quite fussy with their food, or they need to have a bit of wet food for a puzzle toy, or they need to have a bit of wet food to hide medications in. It's good to have those options as well. So from the intact protein range, the Purina Pro Plan EN low fat comes in a dry food for dogs, and it is 2.1 grams per 100 calories ME. So you can see it's right down there where it's recommended in all the literature for helping to manage protein losing enteropathy. So it's a great product to choose. If that pet has other ongoing diseases, so if they have a long history of food responsive enteropathy, if they have ongoing skin disease at the same time as gastrointestinal disease, and if we really feel that a hydrolyzed protein would be better, then Purina HA dry is a good option for these patients. So it's not quite as low in fat as the EN low fat, but again, it's right down there. So it's 2.9 grams per 100 calories ME. The Purina EN low fat has increased medium chain triglycerides. So when I mentioned earlier that some of the essential ones are the long chain ones, they've kept those ones to the sort of minimum that is required because they're essential. But the other fats within this product are the medium chain triglycerides. And these can be much more gentle on the gastrointestinal tract, especially those lacteals, with reducing workload of the digestion of these. It also has inulin, which is a prebiotic fibre. This helps to feed the gut microbiome, which is really important if they've been fasted. Any patient that's been fasted for more than 6 hours, they will start to get a change in their microbiome. So having a good prebiotic fibre in a food will just help to nourish the gut and help repopulate that good microbiome. The regular EN can be a useful choice for our inpatients as well. So it's 2.8 grams of fat per 100 calories ME, and that can be a useful one as well. And both the wet and the dry Purina HA are both suitable for growth. The EN regular is also suitable for growth. So again, we've got those different products available as options for our patients. So where to find this info? Where did I find these numbers from? You might not find them on the pet food labels. There's so many things that manufacturers have to have on the labels. They can't fit it all in, to be honest. So there are ways of finding them. So going on to the Purina Veterinary Product Guide, so either the actual physical paper copy, if you still have one, which is amazing, or onto the Purina's website, then you can get that veterinary product guide to reference. So looking at the as fed, you can find it within the information of each of the products. So they tend to list the as fed fat percentage on here. So that's quite an easy one to find. Also at the appendices at the back of the product guide, you'll find everything in there. So they'll find a different table for the as fed values, and you'll also find the different tables for the dry matter and for the metabolizable energy values as well. So everything is available in there. So you can find it on here. You just have to make sure that when you're reading off from the various products that you're looking between the dry and the wet foods, because they are all listed in the same table, but you can find them on here as well. Again, if you are dealing with sort of longer term management of a fat sensitive patient, or if you've tried a lower fat food and the patient's maybe not responding as you would like it to, there are a few more bits of maths that us nurses might be getting involved with, and that's to figure out the percentage of the calories in a food that it comes from fat. For patients that have protein losing enteropathy, sometimes we want to find out what that percentage of fat that is the calories from fat is containing, and we want to half that. So if we've got a patient that's on a certain percentage of fat in their food, we might want to half that, find a suitable product, and try them on that instead. We'll often try them for sort of 2 to 4 weeks and see if they respond. With the hyperlipidemia ones, sometimes it's 4 to 8 weeks on their low fat foods before we see if they respond. And then we might want to either start some additional medication or some medication if they're not already on any, or we might want to change their food to a much lower fat version. For our patient, and here's it sort of listed on here on where to find it, right at the bottom in that appendices as well. Also with these patients, If we do end up having to reduce their fat very, very low, if they're not responding as we want them to, we may have to opt away from a commercial food, unfortunately, and go to a home prepared food to get the food as low in fat as we need. So sometimes we can't find a product that is 50% less than what they're on just now if they've already started on a fairly low fat food to begin with. And this is where we would refer those patients to a board certified nutritional veterinary surgeon to come up with a complete and balanced food that's very, very low in fat. So we call that the ultra low fat diets, and they are very much of a home cooked variety. So a lot more labour intensive for our clients. So that's why we do always try to find a commercially available food option first, because it's the safest way to feed our pets. So also within the product guides, both on the Purina website and in the physical paper copy, you can find the dry matter values of fat as well. And again, you just have to swap to the right appendices and you'll find it listed here for the EN low fat. So this is their dry matter fat content. And then for those numbers that I presented earlier, again, you flip to the next table and you'll find those grams of fat per 100 calories metabolizable energy. So again, it's just a bit of researching to find the right table to read it off. And that's it up here. So once we've picked a product that we feel is going to be suitable for our patient, we want to do a bit more maths to find out how much of that food our patient needs every day. So our nutritional planning starts with resting energy requirement. So this is the number of calories that our dogs will need every day to get their daily calorie requirement. So we calculate this by using their body weight in kilograms to the power 0.75 times by 70. If the dog has been inappetent or has had food withheld for any diagnostic tests or surgery, or they've had persistent vomiting for more than 3 days, we sometimes don't want to go straight to resting energy requirement amount of calories. We might want to reintroduce gradually. So sometimes we'll start at 25% RER, going up to 50, up to 75, and then up to 100% RER over 3 or 4 days, or sometimes even slower, depending on how they're responding to that food intake. And again, it's all quite dependent on how our patient copes with that amount of food. Sometimes we'll go up quicker, sometimes we'll go up slower. Always be prepared for assisted feeding, so nasogastric tube feeding to get those calories into them. When I first started nursing, we were just sort of coming away from the thought of pancreatitis patients having to be fasted for a period of time so that they stopped vomiting and that what the literature used to say, rest the gut. We know that's not a thing anymore. We don't want to rest the gut. As soon as that dog wants to eat, it should be allowed to eat. And offering small, frequent meals is where you want to go with their feeding plan, and always be prepared to assist feed if you need to. So nasogastric tube feeding, it kind of limits the foods that we put down because they're so narrow bore. They have to be very fine filtered liquid foods so we don't block the tubes. Esophageal tubes are much better, that we can blenderize wet food, mix it with a little bit of water and put those down. So we've got a much better option for feeding through esophageal feeding tubes. But the patient will require a general anaesthetic to have this tube placed. For our very sick patients, so protein losing enteropathy, they may not be able to take in food by mouth at all. So they might not tolerate food by mouth at all, and then they'll have to have their nutrition given parenterally. So they'll have to have a central venous catheter placed and total parenteral nutrition administered this way. But keeping to the Peros feeding plans, small meals. So 4 meals minimum. If you can get 6 meals into your daily routine as a nurse, this is where you want to go. So every sort of 4 to 6 hours, you're thinking about feeding these patients. The monitoring of these inpatients. So again, we want to check on their vital signs. It's part of every hospitalisation sheet in every clinic. In addition to this, we want a nice accurate body weight. So what we traditionally called the CAT scales, I like to call the wee scales. So for small dogs, these scales are what I tend to use. So if the dog, if its feet can fit on these small scales and they are under 20 kilos, these small scales are a lot more accurate. So rather than the big platform scales that are quite inaccurate for small dogs, the small scales that we usually use for cats, I will use for dogs as well. So again, keeping a close eye on any body weight changes. Also hydration status. So the gastrointestinal system will not work normally if the patient is not hydrated. So keeping an eye on their hydration status is really important. So measuring those INs, so how much water they're drinking, their intravenous fluid therapy and any food going in, and monitoring those out. So fecal output, urine output, and any vomiting or any other liquid that might be coming out of an orifice. So for example, a wound, that's sort of leaking serous sanguineous fluid, that sort of thing would be an out as well. So keeping an eye on that hydration status is really important. Pain scoring is really important, and especially with our GI patients, it's abdominal pain as well. So often we'll see they might walk a bit hunched, they're a bit tender when we're touching their abdomen. So keeping an eye on abdominal pain is a really useful thing as well. Fecal score, really important with any patient, but more so with the gastrointestinal patients. So lots of pet food manufacturers will produce fecal scoring charts. Waltham produce a nice one as well. Whatever one your clinic is used to is the best one to use. So as a team, decide which fecal scoring chart you all prefer, and everyone uses the same one. And when this patient is discharged, give a copy of that fecal scoring chart to the client as well, so that they can score in a numbering system how that pet is progressing at home as well. And then when the clinical notes are written, it's easier to read if everyone's using the same scoring chart. Again, with inpatient care, the food types. So what types of foods have been offered and how much have actually been consumed. Then we can work out how many calories our patients have had each day. But also an assessment of their appetite. Are they keen to eat? Are they a bit shy? Do they only eat at night time? Do they only eat if they're not in their kennel? What's their preferences? Do they like wet food? Do they like warm food? Do they like a crunchy biscuit? Will they eat from a bowl, or do they need their biscuits sprinkled on their bed? All these sorts of little nursing skills that we do automatically every single day. We want to make sure we keep really good records of these, so that when we're not on shift, when the night shift take over, or if you're night shift, when the day shift nurses take over, we want to hand over all those little notes about the nursing care of our patients between the teams, and more so at the weekends as well. So if it's completely different staff out of hours, or a different clinic that you send your patients to out of hours, a few nurse notes in the handover make all the difference, so that nurse doesn't have to start from scratch. As I said, the intake, so actually weighing out every gram of food that is offered to that patient and how much they haven't eaten, so then you can calculate how much they've actually consumed. Access to food and water. So if they have, if it's a very tall patient, Great Danes, greyhounds, all these tall dogs, they can often not feed from the floor. So having a bowl of food or water on the floor, they're almost doing a handstand to get their head into that bowl. So having raised feeders can be really useful. Brachycephalic dogs also do eat a lot easier from raised bowls as well. If the patient's got a buster collar on, can they actually physically access that food and water bowl? Or do they need to have a bit of time while you're monitoring them very closely, but they've not got their buster collar on so they can get to that food bowl? As nurses, keeping our patients groomed, keeping them hygienic, clean, especially if they've got a buster collar on and they can't groom themselves, we have to take on that grooming for them. Intravenous catheter care as well. Our inpatients are at really high risk of hospital-related infections. And when they're not well, if they've got a gastrointestinal disease, if they're not digesting food properly, their immune system is compromised. So again, with medications on top of that, it might be further compromised. So we want to keep our patients as clean as possible, really good IV catheter care so they don't develop phlebitis. Also, time to rest for our patients. So if we've got a senior dog or a growing puppy, think about the number of hours they would normally spend sleeping in a day. So giving them time to actually sleep through the day and at night time. So you might have to be that annoying person that switches the lights off in the ward during the daytime and make everyone go around by the light of their phone or their pen torch. But lots of, petting and stroking and cuddling and a change of scenery within the clinic as well. If they've been in for a few days, sometimes they might eat better if you take them out their kennel and go to, a quiet room, a quiet space, the nurse consult room, for example. Also, some dogs do benefit a lot from a visit from their favourite human. So actually having the client coming in and spending a little bit of time just to hand feed them and things can make all the difference to them getting better quicker. Again, a good place where nurses can make a huge difference is at the follow-up of these patients, so monitoring them over longer term. So having a nurse within that discharge consult can, just go over the medications with the clients, making sure they understand which ones can be given with food and which ones need to be given on an empty stomach, and having an appropriate food available for them to hide those medications in. Going through that food. What are the benefits of feeding this food? Why is this client being asked to spend perhaps a bit more money than they've ever done before on a veterinary therapeutic diet? So going through the benefits of the food product that you've picked, making sure they've got those wet, dry and treat options should the client need them, and going through that plan. So remembering to increase your calorie requirement for the patients from RER, that we feed them in the hospital, up to MER. So all of our patients will be doing more exercise at home than they will be doing in our clinic. Even pottering around the house, following their owner around, they'll need more calories per day for that exercise. So giving the clients the volume of food that they'll require, the number of meals, so if they still need to be on 4 meals a day, the timings of that, so don't be squashing those 4 meals into the 6 hours that the client spends with that dog each day. You might have to incorporate an additional person to come and feed the dog through the day. A dog walker and things can often provide this service, or a friend or family member popping in to give an additional feed, or technology. If we've got an automatic feeder that we can load up with food so that the dog gets those small frequent meals, can be really useful. If that feeding from a height should be continued, we want to go through with the client of, are they buying a new set of bowls for their dogs and a raised feeder? What height are they looking for? So demonstrating that. Also, if there's any other special way that that dog needs to be fed, if they've got any esophageal disease and they need to have balls of food, then going through the specific size of those balls with the client so that they know what they're doing. From that discharge consult, you'll get an idea of, is this client perhaps going to struggle to implement all of these instructions, or are they confident enough that they're going to be able to do it? Then that'll determine your time for the follow-up. So doing a follow-up phone call or video call just to get an update from the patient, get an update from your client of, have they implemented all those discharge instructions, and has anything new happened, any new clinical signs, any new concerns? Has the client gone off and Googled, for want of a better search engine, everything that you and your veterinary surgeon have diagnosed, all the medication side effects, and now they're really worried? Being that port of call for our clients to be a useful source of information rather than going down some rabbit hole of misinformation that they may have found on the internet. So doing that quick follow-up call a few days or a week later can be really useful for our clients. and then getting that revisit consultation booked. And again, if you need to do any further diagnostic investigations at that revisit, if there is fasting required, making sure our clients understand that. If the patient's a bit anxious and actually would benefit from some pre-visit medications, discussing this with the client and making sure that they have a supply of those medications and when they should be given is really useful. Time suitable for this revisit consult, both for our nurse clinic schedule, having a nice variety of times that can fit in with our client schedule is really useful. But actually, if your blood samples, for example, all get picked up at a certain point in the day to go to the lab for analysis, do they need to be in before a certain time? So you've got that time to get the blood sample and get it packaged up and sent out. So preempting and pre-planning our revisit consults is a good idea. What do we do when our patients come in? So again, as registered veterinary nurses in the United Kingdom, we can all do a full physical examination on our patients. We also, again, want to get that accurate body weight. So this is the same wee dog that was posing earlier, but this is like his underjumper, as we like to call it. He's got a full onesie on, he's got his harness on. On top of this, he had a snood. He also had a waterproof jacket. So when we have our patients in for their revisits, they have to be naked when they're on the scales. You want to remove them of all their harnesses, collars and clothes to get that accurate body weight. Even some of the harnesses with metal or plastic buckles, they can be really heavy. So getting all these things off the dogs before we put them on the scales is useful. Doing body condition scoring so we can keep an eye. Muscle condition scoring, and I like to do circumference measurements as well. So measuring their neck, chest and waist circumferences, and this in combination with muscle condition scoring, body condition scoring and their weight just gives me a better idea of, are they making the progress I'd like them to make? Do they need to gain weight? Do they need to gain muscle mass? Have they lost weight? And therefore, what have they lost? Is it muscle they've lost, or is it adipose tissue that they've lost? So these, 4 measurements in combination give you a better idea of that patient's actual status. Getting a patient update. So from the client, how are they doing at home? A nutritional update. Do they like the food? That's the most simple, question we can ask. Does that dog like the food? Therefore, are they eating their full allowance every day? Is the dog still on its medication, or has it weaned off? Has there been any side effects of those medications that have been prescribed? With our longer term patients, I like to do the chronic inflammatory bowel disease activity index score, which is a bit of a mouthful, but it's a nice way of actually getting a number to monitor gastrointestinal disease. So the activity index will cover attitude and activity of the patient, appetite, vomiting, stool or feces consistency, feces frequency, any weight loss as well, and then a bit of a skin check. So has their skin flared up or changed in any way? So it's a pruritus score as well within that activity index. And that gives us an actual physical number that we can record in their medical records. If the patient has protein losing enteropathy, there's an additional extended part of this scale. So when we do their follow-up bloods, we can enter another score for any change in their albumin levels, and also in any ascites or any peripheral edema that we notice on the patients as well. So again, it scores that too. Oh, my screen just went blank there. That was scary. So yeah, we can do that too. And again, fecal scoring. So getting an idea from that client of how the fecal score has changed from the discharge appointment. And again, collecting any of those additional samples or any additional monitoring. Is this an elderly patient that maybe we want to keep an eye on their blood pressure? That kind of thing. We can do all that within our nurse consult as well. And then again, making that next appointment for their next revisit. So going on to the sort of longer term management of these fat sensitive disease dogs, their ability to change back to a regular food, or perhaps having additional foods added back in that are of a little bit higher fat levels, will depend on quite a few different things. It will depend on the monitoring of that patient, so their trends of their progress of their disease, on whether they are responded well to that low fat food, and therefore are we thinking they're fixed, let's try a little increase. Any medications as well. So if we haven't weaned them off medications as part of their disease management, then maybe we can't change their food to, at this point. We would often say that weaning them off their medications is more important than changing their food. If they've responded well to the low fat food, we tend to keep them on that and deal with the medications first, because of that risk of side effects for any patient who's on medications long term. So again, we might want to do retesting, especially for things like B vitamins. If we've had to, increase B vitamins as part of their treatment, we often, treat them, with their B vitamins for a period of time. Then they have to have a period of time without supplementation of B vitamins. Then we want to retest. So this isn't often a quick thing. We do have to go for that longer term approach with any nutritional change. But also the patient's, enjoyment of the food that they're on. Do they love the food they're on? Are they thriving on this food? Are the clients managing to feed it exclusively? Is it meeting all that patient's nutritional requirements? Or actually, has the patient now become senior and maybe needs some additional omega-3 fatty acids, for example, to help with joint health care? So all these sorts of things will help to determine whether you can make that nutritional change. Also, your client's opinion is a useful thing as well. Are they satisfied that their dog is enjoying this food? Are they, as the dog using, are they taking it as treats, and therefore the client doesn't feel their dog is missing out on anything because the dog will take this same food as their treats? Are they able to afford to feed this food? Have they got a good source of getting this food either delivered to their home or picking it up from your clinic regularly? Have they actually transitioned all their other pets at home onto the same food? So are all the dogs benefiting from the low fat food and therefore they're all thriving on it? So all these things will determine whether the patient and the client might be ready to change the foods. So as I say, some dogs can be transitioned back, some can't. So lots of different things to look into. And where we make those decisions, when we're picking a new food, we kind of go back to basics again. So we want to go back to the food manufacturers. Are they a registered manufacturer with FHEA for the European food manufacturers, AFCO for the global or North American food manufacturers, or UK Pet Foods are the places to go to make sure the foods that we're picking from are complete and balanced for the life stage of the dog that's in front of us. We often want to check between the fixed formula manufacturers and the variable or the open formula manufacturers. If the dog has had a chronic disease, we often will say stick to the fixed formula manufacturer so that we know that every time they buy a bag of food, what is on the label is what is in that product. They haven't varied any of the ingredients either way. We say if we want to increase the fat, again, it's that reverse process. So no more than a 50% increase in the change of the composition of fat within the foods. So we don't increase too quickly. And again, doing that slow transition. So we often want to do a slow introduction, about 10% of their MER of the new food, and then gradually increase that by the 10% every few days or every week, so that it's nice and gradual over about 2 to 4 weeks. Just a nice, slow, transitional change of food, and monitor really closely. And again, keeping up with that monitoring and that support of the client. Always making sure the client has a stock of the original food that worked, so that if there's any flare up during the transition, they either go back a stage in the transition, or they go all the way back to the food that worked the first time. So they never want to be without that food that worked for their dog. They always want to make that their first choice should they have a flare-up. And that's my kind of intake of fat-sensitive dogs on a whole. So thank you very much. And I think we have time for some questions, Libby.
Thank you so much, Susan. That was terrific. That was really great sort of client-centered approach as well that you have. I think your experience kind of with your nurse clinics and stuff is so valuable. You know, it's very practical, very pragmatic. Think about what the owner can manage to do, what the patient likes to eat as well. You know, so it was terrific. Thank you so much, Susan. Now I was going to do a wee short presentation if I've got time, Paul, just on just to introduce some of our new products, but I will whiz through it because Susan's done a great job already actually of introducing the our EN low fat diet, but let me just share a little bit of information for you. So we've had a few additions to our EN range. So EN is our gastrointestinal range, and I'm sure that many of you have used it in the past. We have EN cat and we have EN dog, but we've had a few additions, particularly to the canine range recently, which I'm just going to bring you through very briefly. So this was the first one, and this change came about probably about mid of last year, and this just to let you know that we now have a little mini can for our EN wet dog. So traditionally it's been in the 400 gram can that you can see to the left there, but now we've got a little mini can which is basically the same formula in a smaller can, so very helpful for your smaller patients, or maybe as Susan was mentioning about using it like as a topper onto any dry food if you've got an animal that likes to have a wee bit of wet in with the dry and you don't want to be opening a whole can. But it's the same formula basically, suitable for puppies with the same sort of beneficial GI ingredients in there as well. The other addition that we've got now is for those little dogs. So we now have an EN STOX gastrointestinal small and mini product. So again, this is a similar formula to our standard EN, but with just a couple of extra tweaks. Just add these. So like our regular EN, we've got kind of the easy to digest ingredients, and that's really beneficial because it helps to kind of make sure that the stools that are coming out the other end are going to stay nice and firm, and decreases the workload of the gut as well. There's that prebiotic inulin in there, so that's in this product as well. That just helps to feed the gut lining and also help with the good bug, bad bug balance, so the microbiome balance in the gut. And then also it's limited it has got long chain fatty acids in it, but there are also medium chain triglycerides in there as well. And that just helps to kind of allow us to decrease the long chain fatty acids a little bit in the diet while still giving all the benefits of fat within that, but it's just less workload for the gut. It's got a smaller kibble. It is not this size. That probably looks absolutely enormous on your screen. That is not the size of the kibble, but it's a smaller kibble than the regular EN. And it's also been adapted. The formula has been adapted to help support sort of that faster metabolism of little dogs. You'll see the STOX in there. And normally that's kind of been on our feline products, but it's also in this product as well. So that's just indicates that the product has been balanced in terms of mineral content in the urinary environment, so it won't exacerbate any tendency to form struvite or oxalate stones. Susan talked about this really well already, actually. So talking about how a limited fat diet can help minimize the risk of fat malassimilation, because we know that malabsorbed fats kind of knock-on effects whenever they're not digested properly and they're passing into the lower gut. We can get several different issues with that, sort of both loose stools, you know, from the water secretion. Also, you can get microbiome imbalance as well. And also it can encourage sort of inflammatory compounds too. So looking at the fat content can be really, really helpful in terms of managing these more sensitive patients. Some conditions, again, Susan's already covered this, really can benefit from an even lower fat diet. So the EN would be a moderate fat diet, and our EN low fat even lower again. And Susan has already kind of mentioned about the levels within it. So this is particularly useful for those animals with a compromised fat metabolism. Still the benefits, it's in the regular EN. I've jumped ahead too much. But it's got a lower level of fat. So it's got 8.1% on a dry matter basis, of fat in it. The only, indication that differs really from the regular EN is that this is not suitable for puppies. So it's got a decent enough protein content, but the fat content will be too low for puppies. But you have the regular EN, and many of our fat sensitive patients and many patients with pancreatitis and so forth also do well on, the EN. But if you've got a query, if you have a GI case you'd like to talk to us about, I've popped our tech line address on there and you can get in touch, and we're very happy to help you with individual cases. So thank you for that. So one question here from Charlotte. So Susan, you said at the start that diarrhea is a common side effect post starvation or GA due to the malabsorption. At what time frame would you consider feeding a low fat food? You know, maybe starving for 8 hours, 6 hours or whatever. When would you consider then re-adding in?
To be honest, for all of our kind of post-op or post-starvation patients, we tend to feed them as soon as they're able to swallow. If they are wanting to eat and they are physically able to swallow food, we will reintroduce food at that point. And we tend to go for a kind of moderate fat. So usually EN would be our go-to food. Other manufacturers do exist, but that's the kind of fat levels. It's mainly because of the higher quality of the protein in that food as well, because undigested protein will also cause diarrhea. So it's that combination of being a really good quality gastrointestinal recovery type food for our inpatients. And it can be down to something as simple as stress, being in a different environment, not having their regular, fully trained human looking after them can just give them an upset tummy because they're not at home. So we tend to go for those kind of moderate fat foods first. Unless we know they've already been diagnosed with a fat sensitive disorder, then we'll go straight with a low fat version.
Lovely. Thank you, Susan. Thanks. There was another question here, a little bit mathsy, but just in terms of converting as fed percentages into dry matter percentages, is there a formula? It's probably a little bit difficult to describe without a pen and a whiteboard, but
yes, there
we could share that probably, couldn't we, afterwards?
Yeah,
I think
there is a formula, and I'm trying to think where an easy place to find it would be. On UK Pet Foods,
yes.
There's a calculator on the UK Pet Food website, and you can put all the as fed numbers into there, tell it the percentage moisture. So if it's a dry food, if the percentage moisture is under 14, they don't have to state it on the label. So we always tend to assume that dry food is about 10% moisture. So put in 10% into that calculator and it will do all the calculations for you. If it's a wet food, they have to state what the moisture content is. So any canned food or pouches of food will state what the moisture content is. And again, you can put all that into the calculator and it will calculate it all for you. That's the easiest way.
Okay, that's lovely. Thanks, Susan. I'm going to jump to a question from Zhao because he posted it really, really early on. And to be honest, Zhao, I'm not sure it's a question that we can answer, but Zhao's got a case of hematuria, which he said after extensive workup, the only anomaly is hyperlipidemia, but the patient is not diabetic, it's not cushingoid, it's got normal thyroid as well. And how likely, he's asking, could the hyperlipidemia be that this is the primary cause of the hematuria?
It could well be, yep. And I know that in Artie's lecture, she definitely mentioned a whole list of breeds of dogs that are not miniature schnauzers that she is currently doing a research project in, and she hasn't actually published it yet, but I wrote them all down on my little notes when I was listening to her. It was like Briards. Oh, can I find the right page? There's a whole list of other breeds of dogs that she has recorded because I think where she is, they have access to like a multi-centred veterinary like practice management system that they can access for their research. So she has found it primary hyperlipidemia in Briards, Rough Collies, Shetland Sheepdogs, Rotties, Dobermans, Beagles, and Brittany Spaniels. So if it's got any of those genetics in the dog, then it might well be that it's a primary hyperlipidemia. So you'll do no harm with a food trial, is what I would say. Food has very few side effects compared to medications, so I would go with a food trial. And as long as the dog enjoys it and the client can feed it exclusively, and you monitor that dog's progress on that, I would do, and then just recheck its bloods.
Going to be my suggestion as well. I kind of think that probably a low-fat food gel might be the way to trial. I honestly am scratching my head about the hematuria if you've ruled out all those other diseases with it. But I think it might be worth putting onto something like a low-fat diet and then check and see what the hematuria does and see how its hyperlipidemia settles down as well. So an interesting case. Martin's asking, is maintaining essential fatty acid levels a problem with a low-fat food?
Not if it's a commercially made food, no, that'll be made properly. That's why we tend to go for them first. The home-prepared ultra-low-fat foods are a last resource, to be honest. If the patient really doesn't respond to the commercial foods, that's when we'll go with that. We never, ever offer it as an upfront one because it's so difficult to get all the fats within a home-prepared food to make sure that all the essential fatty acids are in there. So no, if it's a commercially made low-fat food, there shouldn't be any problems at all.
Of course, also, storage and everything is important, isn't it, Susan?
Yeah, absolutely.
Sure.
The essential fatty acids, they will oxidize very quickly. So always making sure that I've had the privilege of being to pet food manufacturers and seeing, the actual production line. And I've seen the science that goes into their packaging. So with the dry foods, they come in a bag and the food is stable within that bag. So the dry foods are better stored in the original packaging than tipping dry food out into some sort of plastic airtight container. That long-term storage has only ever been studied properly within the original packaging. You can put it in secondary packaging. So obviously crinkly bags, some dogs, that's like, woohoo! That's a puzzle toy in itself. So sometimes keeping them in the bag, having the sort of Velcro or the zip tie at the top, getting rid of all the excess air, rolling it down and putting it in a second airtight tub so that they don't break into that bag can be really useful, especially for, I'm going to say, Labradors that have higher appetite than normal. But yeah, kind of the storage of those foods will make sure that all those fatty acids remain stable. And dry food, usually I tell my clients, once they've opened a bag of dry food, as long as they're using that food within 3 months, then that's perfect. After 3 months, that's when those fats will start to change and possibly become rancid. It changes the smell. So often the dogs are like, that smells funny. So often we'll find that if clients buy a bag, they're thinking they're being economical, they'll buy a big 12 kilo bag for a 10 kilogram Jack Russell, but actually by the time they get to the bottom of that bag, the fats have started to change their smell and the dogs will notice that and they'll start to go off their food at the end of the bag. So yeah, making sure they're buying an appropriate bag size for their daily feeding plan so that they're using that bag within the 3 months is really important too.
Super. Thanks, Susan. I've got a couple of questions about EN, low-fat product, if it's okay if I can just whiz through those myself quickly. So Denise is asking, what kind of consistency is the EN low-fat? She says some patients stick up their nose at the HA because of the consistency. The EN low-fat, Denise, is only in the dry formula at the moment, so it only comes as dry. So hopefully that answers that question. So it's kibble only. And then Sabine's asking, is the regular EN also good for lymphangiectasia? Yes, you can use it for lymphangiectasia. It is moderate to low in fat. It's 11.3 on a dry matter basis. So that is quite low fat. So it will depend on your individual patient, because really with all these fat sensitive diseases, it's a very, very individual thing. So some patients might be absolutely fine on the EN low fat, or on the regular EN. I would choose the dry EN rather than the wet EN, because canned foods are higher in fat. So that's the dry EN. But now you've got the choice with EN low fat, which is even lower, which is 8.1 on a dry matter basis. Something else, Susan, that we didn't mention was about, you can find really low fat foods in commercial diets, but they tend to be weight loss diets, don't they? And not ideal then, obviously, for a patient with a GI problem.
Yeah, absolutely. And again, when you start to go away from those fixed formula manufacturers, they can just have a flare up because that manufacturer has altered the ingredients in that bag of food. So you never really know, is their disease getting worse, or has the manufacturer just, put a bit more turkey and a bit less chicken in this batch, and that's what's caused the flare up. So that's why we do tend to stick to the fixed formula manufacturers initially. And the longer the patient does well on their food management plan, then the more the more inventive we can be. We can, take a few more risks and perhaps add their favourite treat back in again. So there's lots of variable things we can do, and just keeping a really close eye on that patient and chatting things through with the client so they don't just go rogue, go wild and celebrate and give something inappropriate.
And just talking about kind of treats and stuff like that, we've got a question actually around that subject, Susan, with what healthy treats can be offered for these fat sensitive patients, like fresh veg or something like that. Can that be given?
Absolutely. So things like carrots, green beans, broccoli, cucumber can often be really good because that keeps them really well hydrated as well. But with anything you're adding back into the diet, do it slowly. So picking one thing at a time and keeping it as a small portion. So if it's a small dog, it's like half a matchbox size little cube of something in addition, and adding things in very gradually so that you can monitor and get that idea of what's caused a flare up and what hasn't. Because when you're adding in fruit and veg and things, then yes, they will not contain very much fat at all. Apart from maybe sweet corn maybe has a bit more protein, bit more fat. But all the rest, sort of fresh fruit, fresh veg will have very little fat at all. But still, you're adding more fibre. So all these things might have an effect on fecal score. So adding them in slowly, gradually, and then increasing those volumes is a good thing to do, with always being in touch with your clients as well to keep a note of fecal scores and how that patient's doing.
Lovely, thank you. And then just on the topic of adding things in, probably a final question from Rosie about what medications might be added into fat-sensitive diets. I suppose it's not a list, it's not a case that we could give you a list of medications, but some things maybe to watch out for, or...
so I guess there's a huge list of, depending on what the disease is that's being diagnosed, to be honest. It's probably another whole hour of lecture on all the medications. Things, I guess what the main thing would be as a nurse, what our kind of main role is when that patient has been diagnosed with their disease, when the vet has prescribed medications and put all those details in the discharge notes, what I would do as a nurse is, if I'm not familiar with those medications, I would look them up. I would get out the formulary, I would look up those medications, look up all their side effects, and then as I'm chatting with the clients, if they mention any of those side effects that are related to the medications, I would pass that straight on to the vets so that they can make the decision of whether we go for a dose reduction or perhaps remove that medication. So that's the sort of main things for every individual medication that's been prescribed by the vets. And there's lots of different things that they might go on depending on what the disease is. Some of the more kind of simple things that they might go on in addition to food would be probiotics. So they might go on probiotics as well. They might go on B vitamin supplementation. And again, there's lots of by mouth supplementations. It doesn't always have to be by injection. So sometimes you get really good absorbency by mouth in these supplementations too. And I guess other things that clients might want to add back into the mix would be things like their joint supplements later on down the line. So again, these are all omega-3 fatty acids. They're going to increase the fat intake overall in addition. So we want to monitor them closely for things like that. If they say they've got protein losing enteropathy, for example, they're probably the sickest patients that we're looking after. So they may well be on immunosuppressives. So when we've got these patients in for the rechecks, we want to make sure we have not had any, unvaccinated puppies in the room before us, any hemorrhagic diarrhea patients. And we want to make sure our consult room is absolutely spotless before we see any patient that's immunosuppressed from its medication. And making sure that the client is doing lots of things at home as well to protect their pet from the risks of getting an infection. So being in our hospital, they're at a risk of hospital-related infections. Being at home, there's certain things that can increase their risk of infections at home. When my own little dog was on immunosuppressive medications, she wasn't allowed to swim. Being a female dog, when she's swimming, she's a spaniel, she's quite hairy, so she wasn't allowed to swim, just from that risk of developing a urinary tract infection from swimming. So it's all these little life stage things that we, can guide our clients through as well, make all the difference to our clients being, making us, the veterinary profession, the first choice for information.
Oh, that's great. Thank you so much, Susan. Really, really valuable advice, really practical and really empathetic, I think, with your clients as well. So lovely to hear.